Okay, guys. Sam Galvano here. This time I'm from right in my office, right here at the Shock Trauma Center in Baltimore. We're going to talk today about trying to tie together some of our mechanical ventilation concepts. This is really part 4 of this series. So I think we'll make this really interactive. I want you guys to really think through these problems and try to apply some of the concepts. We can go back to anything we need to go back to if we need to, okay? Actually, before we get started, I just want to caveat, the call I'm just getting off, 2 calls that are talking about what is the right way to ventilate these patients. Look, most people are still using what we're talking about, the ARDSnet. I gave you guys a crib sheet on ARDSnet. If you're seeing stuff, I know 10 of you guys are already out there on the front lines, you may be seeing other modes of ventilation such as APRV. And at the very end of this talk, and in the folder that you have access to that I've given you guys, you have lots of resources for how to troubleshoot and learn more about APRV. But that would be part 6 or 7, quite frankly, to this lecture. What we're trying to do is just give you the basic principles. And if you get this down, you can apply a lot of that to advanced concepts like APRV. So I know this is going to be broadcast, and I know by the time it gets broadcast, there may be more talk about how we're doing this right and wrong. And all the goal is here is to give you the concepts, okay? And then you can take those and apply those to other tweaks that we need to do. All right, so, and I'll give you a couple examples. These are patients we're treating right here at Maryland, all right? So let's jump into this first case. 53-year-old. Now, we're seeing all of our patients here, and I know we don't have the volume New York does yet, but it's picking up. It's been picking up. We are not seeing patients that are perfectly healthy, certainly not like you guys. I know that they exist. I know we're hearing about one-offs, but most of these patients have some comorbidities. So this patient in particular, diabetes, hypertension, GERD, and hyperlipidemia, okay? So COVID-19 positive, also has an elevated troponin indicating a possible acute coronary syndrome. Febrile, you see the vitals here. Heart rate's 123, blood pressure is 118/68, and respiratory rate is 36. And the SAT is 82% on 6 liters nasal cannula. So here's the chest x-ray. We talked about this before. You can see some of these patchy infiltrates, this white stuff here. You'll see this more and more as you start working. If you guys are getting deployed out to do this stuff, you're going to see these chest x-rays. You're going to see the pattern over and over again. And there's different levels of severity, but this is what we're seeing here, infiltrates bilaterally. You can see there's a central line here. Some point maybe we'll get into some chest x-ray reading, but that's just for your information. Would you intubate this patient? And if you're gonna, well, I think you know we're gonna, because this is mechanical ventilation talk. We wouldn't be talking about, we wouldn't be talking about this if we weren't gonna intubate. So let's just assume we're gonna intubate. But think about if you're working at a convention center, or you're at whatever, an EMEDS equivalent or something that looks like that, or some form of a medical facility that's a standalone, and you're manning that, how are you gonna decide when to intubate these patients? I will tell you that in the very beginning, we were saying intubate, intubate, intubate. 6 liters of nasal cannula, bam, tube them. Now we're seeing that most of these patients don't do so hot every time when we intubate them. So, we may not want to do that right away. We've got to watch these folks. That's what I think the answer is, close monitoring. And what do you guys think? Let me go back. Would you intubate this guy? He's on 6 liters nasal cannula. Can you go much up more on that nasal cannula or not? What do you think?
No, you can't.
It's the problem, right? You could maybe go to 8, but by the time you get into high flows like that, when it's not humidified, you're going to just dry them out and cause damage, nosebleeds, and the delivery is just not going to be there. So could you do anything else?
CPAP or high flow nasal cannula?
Yeah, that's right. Those are the 2 things we've been pushing. And our friends in New York and Italy have been pushing. You're not happy with the SAT, obviously, right? Nobody's happy with 82%. I will talk to you about SATs. You can live, we're fine with living at 88%, 85%. You guys have all done, probably a good portion of you guys have, all of you have done high altitude stuff, all of you. And if you've ever thrown a pulse ox on, you're going to see your sat's not so great when you're sometimes at altitude or you guys are doing your mountain climbing stuff. So, that's with healthy folks that don't have any pathology, though. These patients are affected because of the pathophysiology of COVID, and that's what we're focusing on. So that's not really a great sat for a COVID patient. And the respiratory rate of 36, I'm just getting off calls with people where they're seeing respiratory rates. I just had a call with the New York guys, actually. In fact, it might be the hospital some of your guys are going to. We had a couple people on. Respiratory rates up to 60, 50. So I think we all agree that this is a patient that needs something more than 6 liters nasal cannula, right? So let's say that here's what the UK folks are putting forth in terms of when you should extubate or when you should intubate someone and put them on mechanical ventilation. So first of all, making sure that they have a COVID pneumonia. So we do need to diagnose this. We got to get the test done because it may be something else that we can reverse, right? The infiltrates, like I showed you. If you have a CAT scan, you might hear your guys talking about CAT scans because I showed you a couple previously, but it's the rapid progression of infiltrates. Okay, so respiratory rate over 30 is a general guideline. That's a pretty high respiratory rate. And then if you have a SAT they say 92%, some people are saying 88%. Here's an important thing we talked about today. If they're using a lot of accessory muscles, or abdominal paradox. What's abdominal paradox? What's that mean? You guys know? Have you seen that? I'm sure you have. So that's where the abdomen moves out in the opposite direction it should when you're normally breathing. And the other thing is that's really important to look at is, are they trying to suck in a big breath? Are they starting to really have retractions and suck in a deep breath? If that's the case, that's a patient that's struggling. And so this is really, you're going to be in your PPE, but you really do have to pay close attention to the signs and symptoms. If they're getting acidemic, if you get an ABG and their pH is starting to drop. Now, what we're hearing is that a lot of these patients don't build up their CO2 very high. Some do. Most of these patients have a primary hypoxia is what we seem to be seeing. And certainly if they start to drop their pressure and they're not responding to fluids, that may be a need to just think about, okay, they're really starting to spiral. We need to get them on the vent. So let me stop there. Have you guys heard anything else in your, reading and such? Anything else to talk about with this? So the big point here.
I have a question.
Go ahead.
Sam.
Yes, please, sir.
Why is, when you get to these equivocal SATs in the high 80s, say, if they're completely mentally normal, would you hold off? Is the brain the last firewall to the decision in an equivocal situation, or should you just go by the numbers? And that's the first question of 2. I'll let you answer that first.
I think, so it's interesting. Literally, as I'm preparing this stuff for you guys and moving through the day, we're learning more and more about this disease. So what I would say are a couple things. The numbers are important. I think it's important to get some data. You definitely have to look at the patient and talk to them. They may not feel dyspneic. In other words, they may not feel like they're in that much trouble. They're going to feel like crap. I think everyone universally feels like crap. Nobody's sitting here on the couch with a SAT of 70 saying, oh yeah, I'm kind of okay. I'm just breathing really fast. It's not the way they're presenting in some form of close to extremis. But to answer your question, I think that's why it's important to really get a good exam on the patient, not necessarily even an exam, just talk to the patient because what we're seeing and what we've seen with similar coronaviruses in the past is that they can affect the nervous system. And what happens there is the patient may not be sensing that they're dyspneic. And these are the patients you've heard about in the media, the young patients who kind of just tried to hold it out at home. They weren't really that bad. They didn't think they were. Some of them got better for a day or two and then got worse. And then they wind up, their wife finds them on the couch. So I think that my answer is they need to be monitored. And I do think pulse oximetry is one thing that's easy and cheap that we can do. But I also think I see this as a role for you guys as Jays, because you guys are really good at patient assessment. And you're really good at doing it quickly because you have to. You guys are really good at this. I would argue any paramedic, one of the most principal foundational skills a paramedic has is patient assessment. I will tell you that I fall back on the skills I learned as a paramedic every day that I'm a doctor. So I would say that's the important point here is you can look at these numbers and if the patient looks pretty good, okay, maybe we prone them, self-proning. That's what's really big right now. Since the last time we talked, it's even more endorsed. And you're going to see that when you guys get deployed to these centers. So I think that what I'm saying is that clinical judgment box really does mean that. It means your judgment, but it also means integrating your exam findings in your interviewing and your monitoring of the patient. What else, sir?
Thanks. The second question is, when you guys in the critical care world talk about O2 sets of 94%, 92, is that stuff empiric and judgment, or is that data driven? Because I've heard so many different stories about that, which is why I go back to mental status.
Yeah, no, I think that a really, really low sat with a good waveform is probably real, and it's probably dangerous. And we are hearing, my friends who I just talked to, again, Mount Sinai, the Queens, the couple hospitals in Queens, I can't remember which one it was, but it's one of the ones getting hit hard. And my friends at Columbia have all talked about this. And these are guys on the front lines that are intubating these patients, and they see that. They see that the SAT is really low with a good waveform. My caveat would be if it's a good waveform and it's really low, that's something to be concerned about. But to your point,
as an intensivist, really low, you mean 70s and 80s?
Yeah, 80s, low 80s. I mean, here, this guideline from the UK, they're saying 92%, but I think most of us would say, you know, what is it, 88, 90? We're not sure. 88.
Yeah, so the ventilator.
Yeah, I mean, if you really look at the classic studies on this, after you drop below 90s, when your oxygen hemoglobin dissociation curve starts to really slant down. At the very end, I can show a picture of that if you guys want to review it. But that's where you really do fall off the cliff, so to speak. It's not linear. It almost becomes like a nosedive. So when your SAT really starts to go persistently into the mid 80s or low 80s, and it's a good waveform, it's not just because they're flipping their finger around or it's not on correctly, that probably correlates to an arterial oxygen level that is very critically low. So I will tell you that we do pay attention to that. Now, if they're a COPD patient, I'm fine with someone in the unit being 88%. In fact, our goal in the ICU is not 100% SAT, which we'll talk about in a second here. I'm perfectly happy with these patients hanging out at 88 to 92%. In fact, I'll write orders to state titrate oxygen levels for that level. So unlike a test score, it's like a test score. You want to get above a 90 to get the A, but you don't get any bonus points above 92. You really don't. So, and in fact, more oxygen can be harmful. It adds to inflammation. So is that kind of the stuff you were hearing, Doc Rush, about that a little bit? The hyperoxia. We don't want to have hyperoxia, but in this disease state, I would pay very close attention to hypoxia, meaning low 80s. Okay. This is a checklist. You're going to have your own checklist, guys. I just want to foot stomp a couple things. If you're going to intubate, and I have intubated a fair number of these patients. In fact, we are just, anyone who comes to the door at shock trauma, I don't care if they just broke their arm outside the hospital, we're treating them all like they have COVID because this stuff seems to be so contagious at this point. So here's a couple things. Definitely do not, and I want to really emphasize this. I know you're going to hear it from Doc Rush, but do not rush in on these patients and try to be the hero to save them if they're starting to go downhill. You got to take care of yourself first, because this will take out several of us, and it has in the past. When we look at the old SARS epidemic, outbreak, we look at MERS, healthcare workers that are getting exposed to this stuff will die. Doesn't matter their age. They could be one of those one-off young folks that gets just overwhelmed with this disease. So I don't want that happening to any of you guys. As we say in pandemics, there is no emergency. Take your time. This isn't a talk on intubation, but I just want to foot stomp this because I myself have already violated this once. I ran in the early couple weeks ago on a patient because they were coding. You know, I had gloves and I had my mask, but I definitely didn't have my N95 and all my other stuff. And it's just in our DNA to do this. So you got to stop and put your PPE on. So please, when you're out there, make sure you're safe. I just want to really foot stomp that. For these patients, it is a true rapid sequence induction and intubation, and I know you guys know how to do that. I'm not going to harp on that. How are we pre-oxygenating them? There's a bunch of stuff out there. MCRIT has some fairly sophisticated, kind of high-end stuff. What we're doing here in my county for EMS, we're just teaching the guys to put a mask on for 3 to 5 minutes with 100% FiO2. We're not doing the nasal cannula because that's extra aerosolization. We're going right back to old school pre-oxygenation, and then it's an RSI, and I'll show you some pictures here. So important to get this filter on your bag. I know you guys wanted a couple pictures. This is one form of a viral. These are pretty good, by the way. They're not perfect, but these will, so when the patient breathes back, you know, it's going to go right out here, right? So if you don't have this protective filter on, this really does take the viral particles out of the game. Most of them, up to 99% of them, okay? So it's really, you got to make sure you get this on, and then when you get them in the vent, you got to also hook this up to the vent. I'll show you that in a minute. Here's the one we actually have here. Sorry, the picture's blurry, but we have just a different type of, just a proprietary filter. But make sure you're putting that filter on before you tube these patients, because you're going to be bagging them, and as soon as you take that off, or while you're not bagging them, but while you're allowing that oxygen flow, you're not bagging them, but you're allowing the oxygen flow to go in, you can wind up with this stuff coming right off the expiratory port through the BVM system. So this will catch those particles and stop it. So I think you guys probably already know that. I think you already had some airway talks. I don't want to harp on this anymore unless there's questions. So here's that patient again. Now, I mentioned the patient had some comorbidities, but it's nothing ridiculous. It's not like the patient's, you know, end-stage renal disease and has had 2 liver transplants. Just has some basic comorbidities, diabetes, hypertension. What I'm showing you here is the trending. And I think this is something that, as we talk about more and more in critical care, it's not, you're going to have the benefit of seeing this in an ICU environment. Even if it's an austere ICU environment, I would still encourage you to pay attention to the trends. Single data points are not what you're looking for. Even with SpO2, you want to see where you're headed. Now, this patient was febrile, not crazy. 38's the level there. You can see the temperature was bouncing around. We actually didn't even meet the threshold at this point. But look at what happened with the respiratory rate. This is where the intubation had to occur. And you can see over here, it's all controlled. They got the respiratory rate nice and regular. This is indicative of mechanical ventilation because they've controlled it. But look how high it got, up to 65, 70. This guy was getting into trouble. Now, to get back to your question, Doc Rush, look at his SAT though. It didn't really fall below 85. So it wasn't a SAT issue. This is what I'm talking about. This guy got in trouble with increased work of breathing, severe tachypnea. The blood pressure was actually kind of okay. But you know, this is the problem. This patient started really falling off the cliff and getting tired and not being able to take effective breaths. So the decision was made to intubate the patient. Does everybody see that trend pretty well? Blood pressure, systolic, diastolic, the SAT, the temperature, and then the respiratory rate. This is the kind of data, and it's going to come in different forms. It depends on what system you're using. A lot of you guys are going to be using paper and pen or pencil. This is what you'll see. But I think it's really critical because you can see in this case, when we're able to capture this electronically, this patient just fell off the cliff. All right, now that's enough of that. Let's go through some settings. So we've got the patient tube. We've done all the right things to get this patient intubated. What are we going to do on the ventilator? How are we going to set up the ventilator? So talk me through that. The patient's 5'10". Let me just back up. I added one more thing, endotracheal tube depth. This is one thing I've been doing on all my intubations. So before I go in the room, I will pre-brief it with my team as we're putting our PPE on, and we will pre-brief the endotracheal tube depth. Why? Because I would argue you're not going to be able to get 8 million chest x-rays to make sure your tube's in the right spot. B, you don't want to main stem these patients. You don't want to put the ET tube down the right side of the chest where it usually goes if you shove it in too far. We want to get this right in the first chance we got. So there's lots of calculators. Again, I use the MedCalc one, or you can use the calculators. I think that's really the way to go. And what do you think the answer is? Let me show you. This is the calculator that's really good. It's online. It's MD Calc, free, and you can actually get your tidal volume when you just put the patient's height in. So that's just one point about the endotracheal tube depth. So can anyone give me an answer for depth? Can anyone tell me what mode of ventilation they would like to use? And what tidal volume? We'll just stop there. The rest we can fill in quickly. What do you guys think?
It'd be like 400 on the tidal volume.
Okay. And how'd you get that? You did the calculation somewhere where you looked at the card?
Yeah, I used the app, and that sort of is like right in the
Okay. Or one of your cheat sheets that we made for you. Okay. Either way, yeah, that's fine. So, and that puts you in the what, 6 mils per kg predicted body weight range? Is that what you got for that one?
That's just over 6, so that might be somewhere around 7.
That's okay.
Yeah.
Great. I agree with that.
Yeah.
What about your mode? What do you want to choose for mode, guys? Sys control, pressure regulated volume control, pressure control, SIMV. And I'm not going to argue there's one right answer. I just want to hear, what do you think?
Assist control.
Okay. So we talked a lot about that, right? That's not a bad place to start. It's a basic mode. So we use assist control, and we've got our tidal volume. And our FiO2, we always start off at 100 on the vent, but then we'll dial that down. You could see this patient was not in severe hypoxemia. Stats were, touching 85, 82 at times, but not consistently horrible. It's really the work of breathing that made us push to this. So what about PEEP? What do we want to set that level to? Any ideas?
What's the patient's weight?
So, okay. Why do you want to know that?
Because I think tidal volume is usually more based just off of height, and then if the patient's like more obese,
Yeah.
then you might need up to PEEP.
Yeah, good answer. Yeah, so I'm, again, not trying to pimp you. I think you knew the answer. That's why I wanted you to communicate that to your colleagues. Yeah, exactly. So sure, an obese patient, they've got a lot of chest wall compliance elastance that they have to overcome. And so maybe a higher PEEP to start if their blood pressure is looking good. Don't disagree with that at all. I think what we're seeing with these COVID patients, though, is just to be careful with the PEEP. Like we said before, they may start with a relatively high FiO2, but that doesn't mean we want to jump right to our ARDSNet tables. We'll show this again in a minute. We don't want to jump right to that high PEEP necessarily until we titrate it up because we need it. So try to work your FiO2 down. Start at a PEEP of 5 or 10. You can add in maybe 10 if this was an obese patient. I'm trying to remember. This guy wasn't terribly obese actually, so I would say weight was somewhere in the maybe 80 kilogram, high 80s kilogram range. We always use metric, by the way. So I'm giving you height here because that's how we all think in the U.S. But we're really converting that to centimeters when you get to this table. That's all it does. So, okay, good. That's good. I think those are all good answers. Remember your modes we have available: assist control, SIMV, pressure control, PRVC, pressure regulated volume control. We've got pressure support. We never go to pressure support right away. That's just not something you're going to do with COVID patients, okay? And in general, we don't intubate someone and just put them right on pressure support. That's pretty rare. There are some instances where we would do that, but for the most part, you're going to use a more invasive ventilation mode. I don't have APRV up here because, again, that is an entirely different animal, and I don't want to overwhelm you with advanced stuff. Although I would argue that's one of my favorite modes personally. I think it's a really good mode for a lot of physiologic reasons. So maybe in the future, if you guys really want to get more advanced with this stuff, I'm happy to talk about it or have one of my colleagues talk about it to you, okay? But these are our foundational modes. And then just once again, think about before you go in the room to intubate, part of your pre-brief, your briefing should be all this stuff here. And I really like this one because it gives you tidal volume and it gives you endotracheal tube. So I will do this before every intubation I go in on, and I'll use to check my tidal volumes, all height-based, as you guys now know. Okay? All right, so here's what they chose for this patient. They did not choose assist control. They chose pressure control. So as a reminder, can anyone explain what that means? What's pressure control mean compared to assist control? Any thoughts? What's the main variable? Is there only like 5 guys on? Because if there is, I'm not going to bother you. Oh, there's 20 people. Okay. I only saw 5 people there. That's why. I don't want to keep asking the same guys. If there's 20 people, I can ask. But if there's only 5 of you, I'm not going to keep pimping you guys on hard questions here. What with pressure control? What's the main variable that we're influencing and dialing on the ventilator to control our ventilation? Remember this? That's okay. It's the pressure. So you're limiting the pressure. You're dialing the pressure knob, and you're telling the ventilator, okay, this is your pressure limit. Whatever tidal volume I get, whatever I can blow the lungs up with, whatever volume goes into the lungs is what I get what I get. But I'm going to limit the pressure. So remember I talked about a pressure of 30 not being a great pressure. Anything above 30 stretches the lung out too much and injures the lung. Now there's cases where we do have to go above 30, but if you're going to start off, 30 is the way to go. Don't go above 30. So that's what they did. They put the patient on 30. Now look at this respiratory rate. Respiratory rate of 12. They picked a tidal volume of 450, which I think we would all argue is a good one. That's okay. I'm not going to get into compliance, but I'll tell you this is a good compliance. So in other words, the patient's lungs were not stiff going on the ventilator. They're nice and compliant. Okay, they're opening and closing well. But here's your arterial blood gas. So 7.19, your CO2 is 68.9, your PaO2 is 106, and your bicarb's 26.9. I'm not going to worry about too much of the bicarb today. But this is where I know you guys are going to need cheat sheets. I see some people writing this down already. You're going to need cheat sheets with this or a calculator, and that is fine. This is not the type of stuff I would ask you to know for the test today or tomorrow, okay? Use your cheat sheets. But having said that, let's walk through this. So I know this isn't an acid-base talk, but before I do that, what do you think about that arterial blood gas? Does anybody want to take a stab in a very general sense? Is there anything wrong with that blood gas that bothers you?
He's acidic.
Ah, thank you. You know, and I love the way you answered that. You didn't try to say it's a primary respiratory acidosis with a secondary whatever. Go to the pH first. If the pH is out of normal range, and we'll remind you about the normal ranges next. If it's out of normal range, you're either acidic or you're alkalemic. You just start there. So I love that answer. Acidic, exactly. Anything else that you see with this that bothers you?
You're hypercapnic.
Oh, bonus question. Excellent. Great. So the CO2 is really high. The CO2 is really high. Okay. 68.9. Why? Super bonus question. Why do you think the CO2 might be high in this case? Is there anything looking at those vent settings that makes you, that you would immediately want to hone in on?
Increases respiratory rate.
Ah, I heard respiratory rate. Yes. So, okay. That's a pretty low respiratory rate. But you know what? If you got a patient coming out of the operating room, or a lot of our respiratory therapists will set this sometimes right at 12 or 15 as a baseline. Okay? So this was an event that just happened. This is right after the patient got intubated, and this is the gas. So the good news is our oxygen is good in this case. PaO2 of 106 is pretty good, but we're acidemic and we've got high CO2. So let's walk through that quickly. So this is your normal pH, 736 to 744. Now, if you want to simplify that and just remember 735 to 745, no problem. And you can do the same with CO2, 35 to 45. If that's easier to remember, fine. I'm giving you ICU level detail that this is what we believe normal ranges are in most ICUs, 736 to 744. So you said that the pH was low, so that puts us down this category of too much acid. Now we look at the CO2 and we look at the bicarb. The bicarb was actually okay, but the CO2 was through the roof, well above 44. And so that led you to believe this is mostly a respiratory acidosis. If you calculate this stuff with the addition of your chem panel with sodium and chloride, and you're going to see when you do this on calculators on your phone, it's going to give you more detail, anion gap. We're not going to go there today. I just want you guys to get the basics. Because with this, if you're sitting there and your intensivist wanders off and has to take care of 4 other patients, and you're stuck with this, you can make an immediate intervention on this basic data. And the intervention is going up on the respiratory rate. It's that simple, okay? So remember this formula? So if you wanted to be really academic about this, all we do, so VE is the minute ventilation, that's respiratory rate times tidal volume. But We only have to solve for respiratory rate because we already know our tidal volume is where we want it. We're not going to mess with the tidal volume. So if you were to do that, anyone want to take a shot at, let's go through this. What would you, so using that formula, your CO2 68, if we wanted to correct this patient to say a CO2 of 45, what respiratory rate do we need to change? We need to go up on the respiratory rate by how much? Go ahead and calculate that through quickly. Let me know what your answer is. Any takers?
Yeah, like 23, 24.
Okay, yeah, that's to really blow it down. And you know what? You don't have to go that high. You could even just say, all right, I'm going to go to 20, and then I'll check a gas or follow my end-tidal trend, my end-tidal CO2 trend. But it's definitely higher than 12, right? For sure. So that's one way you can be a little more precise about this, okay? And you don't always have to correct to normal. You can correct this to 50. So pick 50 as your desired PaCO2. That's your arterial CO2 off of an arterial blood gas, okay? That'll get you there. All right, good. Let's do another case. I've only got 3 cases for you. These are exactly, I literally pulled the data last night. Yes, sir. Go ahead.
You go back to the acid slide with the CO2 and the.
Yep.
Can you just review for the guys and the girl, two women?
Yep.
Just what are other causes, or you could pimp the guys, other causes of elevated CO2 and a reduced CO2, please? for them?
Okay, sure. So what are other causes, guys, of an increased CO2? You tell me. Any thoughts?
Hypoventilation.
That's a big one, yes. And in this case, that's probably what's going on because remember, we were only ventilating at a rate of 12. So hypoventilation is a good one, sure. What else?
Altitude.
Oh, okay, yeah. Altitude will definitely affect your oxygenation more, but it can, you can have some dead space occurring. So anytime you have, do you guys know what's meant by the concept of dead space, physiologic dead space? It's all these, this is the jargon we talk about in, pulmonary medicine and intensive care medicine. Dead space is, it's really simple. It's parts of the lung, they're not dead, the lung's not dead, but it's just not participating in gas exchange. So in diseases like ARDS, acute respiratory distress syndrome, you can have a high CO2 level because you can't get the CO2 out of the lungs. The tissue is very inflamed and it does not exchange. It won't release the CO2 out of the bloodstream into the alveoli and out, okay? So dead space is lung tissue that is not participating well with gas exchange. And I've got a good handout in the folder, which I'll give you guys access to again at the references at the very end of this. That mini Dropbox showcase has a one-pager on physiologic dead space. And I would review that if you can. I can go back, I can look at it now if you want, but I don't think we need to. But that's one of the other causes. What's a cause of a really low CO2? So let's say that our gas comes back and we've got a high pH, 754. So we go down this track. Now we're alkalemic. And we have a low CO2. What can cause a low CO2?
Hyperventilation.
Thank you. Excellent answer. So hyperventilation can cause it. The opposite of what you said before with hypo. Hyperventilation can absolutely cause it. What else can cause that? Any other thoughts? Low CO2.
Death.
I'm laughing, but you know what? That's actually one of the most predictive things we've got. There's a whole bunch of papers looking at end-tidal CO2 levels of less than 10, which you guys have available, and you know this stuff. And survival from like blunt traumatic arrest, very bad, very, very bad survival, virtually no survival. And penetrating trauma, same thing. End-tidal CO2 that's low is a very, very bad prognostic indicator, absolutely. So, so there you go. Those are two of them. Another one that you can sometimes see is if you remember we talked about main stemming the ET tube. Sometimes you'll only be ventilating one side of the chest, and you can have a low CO2 with that. You won't necessarily get alkalemic with that. You might get a more of an acidemic picture, but you can wind up with a low CO2. And then, and getting into the bicarb, Doc Rush, I can go there. In fact, I have my own way of teaching ABGs. If you guys want another ABG talk, I can give you my ABG talk. But we're gonna really, if we go that road, we're gonna really get into more of a comprehensive ABG analysis. And I'm prepared to do that if you want. I am. But are we okay to move?
I'll let you
Go
go
ahead.
through your cases, and if we have time, we'll come back.
Okay.
I appreciate the redirect. That's fine.
No, I'm happy to redirect to that because I love that stuff. And that's why I like intensive care. We talk about acid bases all the time. Okay. So I love this stuff and I love talking about it, but it really, to do it right, does require a little more than this diagram. I'll argue to you guys, even at a very basic level. If you really want to do acid base, you have to look at a couple other things, namely the anion gap. Very important. Okay. All right, we'll move on to another case here just to illustrate some more concepts. So like I was saying, these are absolutely actual cases. Every piece of data here, I didn't make any of this up. This is a 28-year-old guy. Now this guy, okay, this is one of the outliers. No real medical history, and he's young. He's 28. But he had a history of cough for 5 days, shortness of breath, febrile on the first day, lots of dyspnea at rest. Dyspnea at rest. And his sat on room air is 85%. Now here's his chest x-ray. It's a little worse than the last guys we showed. I'm not going to ask you to interpret this, but what I'll point out here are these patchy infiltrates of lung tissue that are now inflamed. Normally these lung tissue, it should be much more darker black, and this is a bad chest x-ray, okay? You can see some other things they've already done, like a central line. There's some other tubes, EKG leads. So we're not going to get into chest x-ray reading, but just the site recognition of what this disease tends to look like. This is a classic x-ray for a COVID-19 patient, okay? So let's go through this again. Let's get your calculators or your cheat sheet. I don't know if you can see the ArtsNet card, but this is the card. I just put together a 2-pager for you guys. I think Doc Rush got that out to you. It's just a crib sheet, but what do you think about for, well, first of all, for ET tube depth, what do you think? What are your thoughts there?
Speak up. Somebody answer.
20 to 22 at the teeth.
Okay, good, like it, yeah. You know, I mean, yeah, that's a good answer, sure. The key with this patient, he's a little shorter, so you might want to be careful with that, right? 22 is always a good answer for men, 20 for women, but I think for this guy, I'd probably err on the side of maybe 20, 21, but that's good, but that's important to brief, like we talked about. What about your tidal volume? So 5'7" is how many inches?
67.
Okay, and so looking at the chart, and man, I'm looking at this, and maybe I'm just getting old, but you guys might need a better card because this is awfully hard to read. You can use your phones, but so looking at this, what are you thinking for? What are you tracking on for tidal volume?
Like 400.
Yeah, 400 is going to put you right on the nose with like 6 mils per kg. So good, perfect answer. Now, if you go a little above that, that's fine. You probably don't want to go too far below it, and you definitely don't want to go in the 10 mil per kg range. That's really bad. So 6 to 8 milliliters per kilogram based off of both their gender and their height. Good. What respiratory rate? Anything you want to pick on that?
20.
Any thoughts? Okay, fair enough. So we got our tidal volume. What mode are you going to use? The reason I'm asking is I just want to see if you guys are remembering some of the modes off the top of your head, because you're going to see, as you do this more and more, you'll see it, you'll get it. It's going to be like just, you know, kind of like all the other things you do in your profession that you get really good at because you do it so much. you'll start to see these modes and understand what they are. But just for the sake of going through that again, what mode would you want to use? Any thoughts?
Assist control.
Okay, assist control again, no problem. Okay, and then like we talked about with the PEEP, adding in a 5 a PEEP is always a good place to start, and you can work on titrating that up. So this time they did choose assist control. They chose a tidal volume of 420. So you said 400, so they chose 420. The rate was 20. PEEP. Now they went up on the PEEP a little bit more than. This patient was probably a little more hypoxic, so that's why they did that. But they brought the FiO2 down to 40%. So okay, no harm, no foul here, but that's just what they did. And now here's the blood gas that they have for this patient: 749 pH, a CO2 of 32, a PaO2 of 73, and a bicarb of 28. So anybody want to take a stab at that? Is that okay? Are we all right with this?
It's a little alkalemic.
Excellent answer. A little alkalemic. A little. It's not horrible. This is the type of patient where we're just doing some fine tuning. The last patient, I would argue, needed to really go up on that respiratory rate. This patient, I think we're kind of doing okay. We just need to make a little bit of an adjustment. What do you think about this PaO2? And I don't expect you to know normal values for PaO2, but are you okay with that? Is it concerning? What do you think? Is it low? Does anyone want to take a shot at that?
Yeah, it's starting to be a little low.
It's starting to be low. Yeah, I mean, so this again correlates to your SpO2 is your pulse ox. The PaO2 is your arterial oxygen level. Okay, and and in this case, it's low. It is low, but it's not catastrophic. Bonus question. Anyone remember from ArtsNet how low we're okay to go to if we need to? What's our cutoff for PaO2 before we do other things? Does anyone remember? If you got your card in front of you, you'll see it. So we're okay with a PaO2 of 55. This gets back to Doc Rush's first comment. How low can you really go without getting in trouble? A PaO2 of 55 or greater is compatible with life. Now, most of us are going to want that to be higher than 60 or so. So there's not much we need to do. I probably wouldn't mess with the PEEP a whole lot because we're already on 40% oxygen, which, by the way, 40% FiO2 is usually the kind of the low level of mechanical ventilation. We don't, for these patients that are this sick, we don't usually go much below that. Sometimes we'll go to 30%. We're breathing 21% right now, right? So on the ventilator, we give a little bit more. That's a pretty low level of FiO2. So I probably would leave that where it is, but would you want to do anything with the rate?
Go to 18.
Yes, thank you. There you go. So once again, this was a patient who was alkalemic. Their pH was slightly 7.49. So that's above normal. We're in the alkalemic category now. And we've got a CO2 of 32. 32 is low. So we go down this pass, and what we're doing is our rate is just a little too fast for this patient. We just need to make a slight adjustment there. Guys, this is the kind of stuff that we would expect if you're with me, now Javits Center, but if you're with me at the Baltimore Convention Center, and we're leading a team of you guys, 4 or 5 of you following 1 or 2 patients each, or just 1 patient each. This is the kind of stuff that really helps us, because if you come to us with a solution like, hey, doc, got the ABG, got some alkalemia, I did some calcs, I think we need to adjust the vent, I think we need to come down on the rate a little bit. That is a force multiplier, We're talking about models of having 1 intensivist to 96 different patients, 96. And the best models, things that I've been working on here, we're looking at 1 to 40 patients, 1 to 20 patients. Right now, we're not at that level in Baltimore yet, but we're predicting we're going to get there by the 18th. So if you can do these small, this may seem trivial and not that sophisticated, but these are the types of things where I can see you guys stepping in and making a difference. And furthermore, if you're doing a long-term, and I know several of you, like the Alaska guys, you guys do these transports. If you're going to be doing transports on ventilation, this is the kind of stuff you're going to be doing en route, making small adjustments, okay? That's what our critical care transport guys do here in Maryland when they're going hospital to hospital. So there's the formula again. You know how to do that. So here's the gases, just to give you a picture of what this looks like. It goes from right to left. The most recent gases are here. I gave you this one. This patient, you can see, has tended to have a little bit of a higher CO2. Actually, I take that back. The gas I just showed you is not these. This is later. So just to give you an idea of how it looks, this is how your data is going to be presented. It's going to give you the data in a table form if you're using an electronic medical record, or it'll be written out like I've been showing you here on the slides, but this is kind of what you're looking at, okay? I'm not going to get into this. I'm just showing you, I want to show you some of the data that you'll get potentially with some of these patients, and you'll get really good at tracking this and writing it down. All right, one more case, and then we'll open it up for some questions. Now, this is a different patient. This is an 85-year-old male, history of herpes zoster. That's it, but he's 85. So that's a comorbidity right there. 85 is up there for this disease. Not a good outcome. We're seeing very high mortality at this age group. He's weak. He's got a fever. He's treated for a urinary tract infection by his primary care provider. Doesn't get better, okay? Gets worse. He gets admitted to a medical floor. They do a COVID test on him. He's positive. And now he's got respiratory failure. So he's not a DNR. I'm going to tell you that if this really continues to get bad, I'm hoping in New York, we're starting to plateau. I'm really hoping for that. Because guys, if we don't, this 85-year-old is not going to be even a candidate for mechanical ventilation. It's just, we're not going to have enough ventilators. I think we're going to be okay. I think the public health interventions and our resources are probably going to be okay. And in fact, this is our institution right now. We still have a lot of resources and a lot of people ready to go. And so we did put this guy on mechanical ventilation. And I just want to review this because I really like it. So MCRIT has some phenomenal, phenomenal resources. If you were to only pick one website for this COVID stuff, I have to say probably that website's the one to go to, honestly. There's a lot of high and advanced stuff there that I'd be careful with, but overall, really good website. So they talk about 1 to 6 liters, just like we had in that first case. So you escalate that. You can go to high flow nasal cannula, which we've talked about, can deliver really high flow rates. So you guys know what a nasal cannula is. You know you can give 6 liters a minute. That's kind of your maximum, right? Is that your maximum by protocols? Do you go to 8? 4 to 6?
6.
Something like that? Okay, 6. Gotcha. So 6. So on a high flow nasal cannula, we can go up to 40 or 60 liters per minute. So that is a lot of support. So yes, if they're sitting in the room with a high flow nasal cannula on, you may say to yourself, oh, they're on a nasal cannula. They're not that bad. Just remember, this is a tremendous amount of support. And by the way, the FiO2, the oxygen concentration, can be extraordinarily high as well. You can give up to 100%. So if you see a patient on a high flow nasal cannula, that is a high level intervention for respiratory failure, okay? So for these COVID patients, we're trying to do more of this and CPAP, continuous positive airway pressure. Just remember, if you do this, we do talk about the filters here, okay? We're trying to really use these. See how these are the biggest blocks here? We're really trying to use this as our frontline therapy. I have got a nurse, an ICU nurse. She won't mind me talking about it because she's not military, but she's a very good nurse who we are managing right now. And of course, she's got, you know, we got her on the floor and she's got COVID. She's young. And we're right here with her right now. And we're watching her literally hour to hour to see if we need to go further. We really don't want to intubate her. We don't want to do mechanical ventilation. We're finding that a lot of by the time we do that, the mortality jumps up tremendously, okay? Anywhere we're seeing reports of some hospitals are 90% mortality. That's extreme. We're seeing stuff from Italy and some other places in the 50% range, okay? So it's not insignificant. If you can get away with not intubating, try to do all this. And then the awake pronation. So this is a much stronger recommendation than the last time we talked. I think it was maybe 2 talks ago. I would say all the way, just make sure you can monitor them. And if you can help have them self-prone while they're on a nasal cannula or CPAP, go for it. Just make sure while you're doing this that you're not contaminating yourself. Because if the nasal cannula comes off at that kind of pressure and flow rate, you can spray it right in your face, okay? Then we move to mechanical ventilation, we move to proning, and then finally VV ECMO, which is blurred out here, but we do that here at Shock Trauma. That's where we're getting a lot of our patients for, is to put them on ECMO. But that's the last ditch, last stop. this patient's 6'1". So real quickly, just give me a tidal volume, and then I just want to move through this one more time. Just give you some, I want you to get used to doing this, thinking about what you need to answer for these patients. So if you're putting this patient on the ventilator, you intubate. And here's the thing, here's the other thing while you're doing that calculation. You could be doing this because if you're with, you know, your intensivist and maybe they're outside the room and you're in a sealed up area, it's just you and the nurse, but you're the airway manager. You know how to get an airway. That's not the issue. So you get your ET tube depth, and then you're going to be putting them directly on the ventilator. We do not do the old, let's get them on the BVM, give them a couple breaths, get our end tidal, listen for lung sounds. We're not doing that with these patients. We're putting them right on the ventilator immediately. So you may be doing this. So before you go in the room, set this up, get your ET tube depth. This we have found to be a very helpful way to not contaminate ourselves. So what has anyone got for ET tube depth? What's anyone got for tidal volume for me?
Tube 23.
Okay, cool. So a little different than, because they're 6'1", this guy's a little taller. I will lie that I inflated his height because I just wanted to see if you guys would catch that, and you did. So thank you. Good job. And tidal volume.
480.
Okay.
Start maybe 5, just round it up a little bit.
Now, absolutely. So that's fine. And then respiratory rate, like we've been saying, you can kind of pick it 15, 16, whatever. FiO2 100 and pull it down. And then PEEP will depend on the weight. I agree with that statement before. If this is a 6-foot guy, but he's a big 6-foot dude, yeah, maybe a little more PEEP would be a good move. Okay, so sure. Here's the chest X-ray. This chest X-ray is not that bad, guys. He's 85. He's got a pretty clear diaphragm. Not a lot of infiltrates. A little bit of junk over here. You can see that white stuff. Some infiltrates here. By the way, the one on the right here is the right side of your screen is his initial chest X-ray, and the left is his most recent. So he's deteriorated a little bit, but this is not a chest X-ray incompatible with life. Put it that way. So the good news is here's where he's at today. He's now on pressure support. So pressure support meaning that he gets some pressure every time he takes a breath. The ventilator pushes some pressure into the tube to help him breathe, so he doesn't have to work as hard against that tube, breathing through a straw. And then he's got some positive end expiratory pressure added to the system. That's the back pressure to keep those lungs open so they don't collapse. He's breathing 22 times a minute. He's got a 40% FiO2. So we've worked him down on the FiO2. He's getting better. He's not as hypoxic. So here's the question. When are you going to extubate this guy then? When are we going to say, hey, let's declare victory. This guy's good to go. Let's get him off the vent so we can use that vent for someone else.
What's his O2?
Go ahead.
Go ahead.
Oh, what's his O2 sat?
Ah, see, you need more data, right? So his O2 stat is actually pretty good. It's 95%. What else you want to know?
Doc, what mode are we in? Are we in SimV? Is he trying to take his own breaths?
Yep.
Is he trying?
So we're not in SimV. We're actually off SimV. We're on pure pressure support. So this is what he's doing. All we're doing is giving him some pressure in so that when he takes a breath, he gets a big influx of pressure. Not much, 10, which isn't much. And then when he breathes out, we've got back pressure in the system, the PEEP, the end expiratory pressure. As he exhales, he breathes against pressure, okay? And that keeps his lungs stented open so they don't collapse shut. That's all we're on. Anything else you want to know?
Yeah, what's his last ABG?
Ah, okay, good. So his last ABG is good. You know, I'll just say it's good. But that's the data you want to look at, right? You want to make sure he's not acidemic or alkalemic. Good. Anything else?
Yeah, what's his mentate? Like, is he like aware that he's intubated, or like is he?
Ah, thank you. Excellent, excellent, excellent. So I've got the normal values laid down here, guys. So here's the thing. He is awake. He's a little delirious, so not quite ready to be extubated, because to be extubated, you're hitting on a really important point. You've got to have an intact mental status, okay? So I'm going through the extubation quickly because I'm hoping if you're deployed, you will be extubating patients. I really hope that, okay? I hope we get through all this and you're at the point where you're helping pull the tubes out on these patients. Literally, Okay, that's a really good thing if that's happening. Here's his gas today, 746. So just a little bit, alkalemic, not bad. His CO2 is 39. That's in the normal range. His PaO2 is 77. Now he's older. He's 85. Your PaO2 depends on your age, and there's various calculators out there for that. But this is not, while this is really low, it's not horrible. And it might be acceptable for him. So I'm just leaving that out there for you. But you can see he's not on a lot of support. This is a guy we're getting ready to liberate from the ventilator. And the right term is not, we talk about vent weaning, but the right term is really discontinuation or liberation from mechanical ventilation. That's the technical ICU term, okay? And you have to make sure that, first of all, the COVID is better. You got to make sure his gas exchange is good. Here's some general guidelines, guys. I'm gonna blow through this, but because you said a lot of the same stuff, but there's some other common sense things. You got to make sure you're not suctioning this guy every hour, because if that's happening, he's just going to plug up his airways, and especially in older patients, and he'll plug himself up, and then he'll wind up having a respiratory arrest. So you've got to make sure that they don't need to be suctioned too much, and then that they're not hypercarbic. Good cough, good neurologic exam. Are the hemodynamics stable? These are some general things we're looking at when we liberate someone from mechanical ventilation, okay? And you guys actually did really good with that, because you named a bunch of these things. You asked about what mode, you wanted to get some extra data. You didn't just rush into it and say, yeah, he looks pretty good. He's breathing 22 times a minute. His chest x-ray looks a little better. Let's do it. No, you shouldn't do that. What we're seeing also with COVID is you'll see some of these patients get better for a day or two, maybe a couple days, and then they just plummet again. And we don't know if that's the virus replicating and overwhelming them or what's going on there, but that's what we're seeing. Okay.
Hey, Doc, quick question on that
Sure.
neuro exam. What kind of neuro exam are you checking on the patient that's
Yep.
multi-sedate? Are you just checking like pupillary reflex, like vestibular, like what are you checking?
Good question. So you really are doing a neuro exam. So this is where we do what's called a sedation titration trial. We used to call it a spontaneous awakening trial, but the problem with that term is everybody would go in the room and just shut everything off abruptly, and then you'd have patients emerging from high doses of opioids and sedatives, and they'd like go into instant withdrawal. So the term is sedation titration. So to answer your question, what we're doing is we're dialing the sedation down slowly on the pumps, okay? Waking the patient up and doing a neuro exam, but not like a head to toe neuro exam, just kind of like, can they talk? Can they blink their eyes? Can they follow commands? Can they move all extremities? You can do, this is a whole separate talk on ICU delirium. You can do a quick bedside test to see if they're delirious. It's called the CAM ICU test. And that's what you're talking about there. It's not like what you're thinking, like, oh my gosh, I've got a cold water calorics and corneal reflexes and pupils. It's really a more generalized, are they awake? Are they following commands? Do they look strong enough to tolerate this? A lot of times when they're ready, you'll say, hey, are you ready? You want to get that tube out? They'll be nodding their head like, yeah, I want this tube out now. I'm ready. Let's go. That's the kind of exam you're looking for. Okay?